So our trial is a Canadian Cancer Trials Group PR21 study, and we conducted the study to compare two treatments, lutetium PSMA-617 and docetaxel. The background to this is that lutetium has proven efficacy in patients with metastatic castration-resistant prostate cancer that's progressing after an AR pathway inhibitor. However, also a standard of care in this setting is docetaxel chemotherapy, and the two have never been compared. So to inform clinical practice, we conducted this study. The study design was that patients had to have metastatic castration-resistant prostate cancer that was chemotherapy naive, and they had to have been progressing after an AR pathway inhibitor. They also had to have PSMA PET positive disease, so all patients had a PSMA PET scan at screening, and they had to have adequate kidney, liver, and bone marrow function. They also had an ECOG performance status of 0 through 2. Patients were randomized 1-to-1 to receive either docetaxel at standard dose and schedule or lutetium at a standard dose and schedule, and they were followed for radiographic progression. Now, perhaps unique to the study, not only comparing an active treatment versus an active treatment, but also on protocol at progression, patients could cross over to the opposite treatment, and then they were followed for second progression. The primary endpoint was radiographic progression-free survival with the first treatment, and then we had other endpoints including overall survival, tolerability, and quality of life. So what we found is that we had 200 patients that were randomized, actually 199 patients that were randomized. What we found interestingly is that equal number of patients received the treatment. However, about 15 patients on the docetaxel arm came off early because of treatment-related adverse events, while only one patient on the lutetium arm came off early because of a treatment-related adverse event. What we also found that was interesting, and will have a little bit of impact later as I talk about the results, is that there were more patients that crossed over from docetaxel to lutetium, 56 patients, versus 38 patients that crossed over from lutetium to docetaxel. So there's a bit of a difference there. Post-protocol therapy, 10 patients in each arm received subsequent life-prolonging therapies. So that was the same. So the big difference there is how many patients crossed over. For the primary endpoint of radiographic progression-free survival, there was no difference. The treatments were the same. Median time to radiographic progression was about 8 to 10 months. Hazard ratio was 1.01. Now, on subgroup analysis, there was no evidence of a differential treatment effect on various prognostic subgroups. And we even looked at PSMA PET SUV mean. So this is how much uptake there is on the PSMA PET scan or the PSMA radiotracer. And we split the group along the median, so either a low PSMA SUV mean or a higher PSMA SUV mean. And what we expected, I'll be honest, is that we thought patients with a higher SUV mean would benefit more from lutetium, and a lower SUV mean would benefit more from docetaxel. But in fact, we didn't see that at all. It was prognostic, meaning that patients that had a lower SUV mean did worse, but there was no differential treatment effect. Both treatments worked equally in whether they had a low or high SUV mean. The treatment-related adverse events were as expected for both, but certainly there was a lot more toxicity in the docetaxel arm. 34% of patients had a grade 3 or 4 or higher treatment-related toxicity, while that was about half the amount in the lutetium arm. As well, there's 2 deaths that were considered treatment-related, and they were both from chemotherapy, from the docetaxel chemotherapy. Now, so all of that was kind of not a surprise. We thought that there was probably not a big difference, but that the tolerability of lutetium would be better. But what did come as a surprise is that overall survival was different. The hazard ratio was 1.64, and this was statistically significant, p-value 0.02, and it was in favor of docetaxel for the patients randomized to initial docetaxel. And median survival was about 18 months versus 14 months for the patients receiving lutetium. Now, this could be because possibly of the differential crossover, but this was an intention to treat analysis. So overall, we conclude that there is no difference in radiographic progression-free survival between lutetium and docetaxel, although lutetium seems to be better tolerated. As well, the response rates were higher. Better tolerated, less patients were coming off for side effects. However, there is this overall survival difference from a differential crossover effect, possibly, but we really need to look at more data to see why this is. We're going to be doing further analysis. We'll have longer follow-up on survival. We also have a lot of correlative studies, quality of life studies, and as well we looked at serial circulating tumor DNA. So we'll look at some of biologic correlates and to see if there's any other biomarkers that we could find that are prognostic or predictive. Outcomes with lutetium are very similar to docetaxel in terms of radiographic progression-free survival, but it is better tolerated. There is an overall survival advantage if you get docetaxel first, and so we have to really look at why patients weren't crossing over from lutetium to docetaxel. Was it because they didn't want to? In fact, a lot of patients don't want to get chemotherapy, or was it because they couldn't? Docetaxel can be hard to deliver after lutetium therapy, potentially. So we really need to delve into this. Regardless, I think we have to recognize that docetaxel chemotherapy is a standard of care, does improve outcomes, and people should consider it more.